Moving along, our second working group annual report is for the Genomic Medicine Working Group of Council. And today's presentation is going to be given by Teri Manolio, who's the director of the Division of Genomic Medicine at NHGRI. And Teri, I see your slides up, so take it away.
There we are. Okay. And you see them now and you hear me?
Yes, I see them in presentation mode.
Excellent. All right. Thank you very much. I appreciate the opportunity to update Council on the Genomic Medicine Working Group. We'll keep this relatively brief. You've heard from us before, but what I did want to do was to remind everyone of the members of the Genomic Medicine Working Group. They're listed here, including a current member of Council, Pat DeVerka, and several past members of Council. And just to remind you of the working group's charge from you is to assist in advising NHGRI and its council on research needed to evaluate and move genomics into routine medical practice. This includes reviewing current progress, identifying gaps in research, implementation, and education, and then pointing out some approaches for filling them, identifying and publicizing key advances in genomic medicine, planning a series of meetings on timely themes, and facilitating collaborations, coordination, etc. Focusing for a minute on the publicizing key advances, we meet every month and review a number of papers that have been pulled from the literature by our outstanding program analysts, currently Madison Goldrich. We then have a series of criteria that I'll describe for you, and those that sort of pass muster across those criteria are filed away in this archive that's made available on our website for everyone to use. It is searchable. Our web team has done a fabulous job in putting this together. There are a number of categories. You can search by date, etc., and then you see the papers here and get a link to them in PubMed. If I can advance. The criteria include things like involving the use of patients' genomic variant information in clinical decision-making, demonstrating impact of implementation on health outcomes, likely to be generalizable beyond the original setting, likely to have implications for healthcare systems or guidelines, sufficiently large and rigorous to overcome sampling error and other biases, and are broadly representative of the field. We've also added a category for resources, this first one here, that don't necessarily fit all of these or any of these categories, but still are important, we feel, resources that people can use. And these are the other categories that are listed in the archive and are searchable. We also, at Pat's suggestion, developed last year what we call the Genomic Medicine Year in Review. This was accepted for publication as a regular feature through the American Journal of Human Genetics, and we repeated that then this past year. It was published in December, and you see here sort of the update of that. This is an overview or a summary of the various categories of both the sort of top 10. What we did was to highlight 10 papers that we felt were particularly noteworthy and provide a very brief summary of them along with a link out to them. But you can see that in purple are the highlighted papers that are in darker purple here. For instance, there was one highlighted in risk assessment and prediction in 2019. In 2020, there were 3. But there was a larger proportion that were included in the resource. And similarly, systematic implementation, so the blue categories, there weren't any highlighted in 2019. Some of these are new categories, et cetera. So just gives you kind of an overview of where the field is going. You'll note one of the big differences was that sequencing came into its own in 2020 with a lot of sequencing going on in genomic medicine, which hadn't really necessarily been the case previously. And if you feel that you're aware of a paper that should be highlighted in this effort, please send us a nomination any time of the year. As I say, we look over these monthly. One of the other key things that our genomic medicine working group does is to organize and hold a series of genomic medicine meetings. We started them out actually shortly after, just a few months after the publication of the 2011 strategic plan, and held them initially every 6 months, then every 9 months, and now they're about once a year, except during pandemics when we sometimes have to spread them out a little bit more. Our most recent one, Eric described for you briefly, our clinical informatics research agenda was held, oh, this is going to go by itself, was held in February, and I'll mention a little bit more about that. Some outcomes, I've shown you this in the past. I've simplified the slide a bit because it's getting a little bit crowded. But shortly after we held our first meeting, we then convened a meeting that we called ClinAction that was focused on how we could get to this issue of trying to identify actionable variants. And you can see it here. That led to our clinical genome resource and the Genome Connect patient portal. It also led to a pharmacogenetics implementation in our eMERGE network. The second meeting was on forming collaborations, and it led to the Implementing Genomics in Practice, or IGNITE network. The third meeting on stakeholders led to close collaborations among, and it's recognizing the need for those collaborations among payers and labs, which figured prominently in the development of our CSER consortium, the first phase of that. The fourth meeting on professional education led to the ISCC that Eric mentioned to you earlier. Our sixth meeting was a global meeting that led to the Global Genomic Medicine Consortium, which is an international network of groups implementing genomics in clinical care, as well as the now not to give anyone a headache, International 100,000 Cohorts Consortium. Our eighth meeting led to a program recently released, actually, to produce genomic medicine modules for training modules. The ninth meeting contributed heavily to the variant function and disease program that has been quite successful in the past couple of years. Our 10th meeting on pharmacogenomics led to a number of pharmacogenetic clinical trials, most notably the ADOPT PGX trial, which is part of the second phase of the IGNITE consortium. Our 11th meeting on implementation led to a fairly significant interaction with employers, looking at how we could implement genomics in some of their wellness programs. That's still a dialogue that's ongoing. Our 12th meeting on risk figured heavily in the development and continues to in the eMERGE network's genomic risk assessment phase, and also contributed to the PRS diversity, polygenic risk score diversity program that you all saw previously and is about to be awarded. And then our 13th meeting, stay tuned, and hopefully we'll have something for you on that shortly. And as Eric mentioned, all of these meetings are archived, and materials are available on the division's website, the Institute's website. You can see the executive summary and meeting summary, as well as video casts of them and the slides from them. And this just overviews the objectives of that February 2020 meeting on clinical genomics informatics research agenda, defining the current status, determining facilitators and barriers, and identifying the research needed to improve how this is done. This was led by my colleague, Kenneth Wiley, and Mark Williams, who's one of the members of the Genomic Medicine Working Group. And we hope to tell you more in coming meetings about the products of this effort. I did want to review for you the portfolio of the Genomic Medicine Research Program. This is something that the group reviews actually in annual in-person meetings, although this year it of course, was held by Zoom. You've heard about the UDN, the Undiagnosed Diseases Network is a common fund program, but it's led heavily by NHGRI staff. And now we welcome Arjuna Das, who's the new program director, who's actually sort of on loan to us from the Neurology Institute. This is the total amount of funding that's been spent on this program in the years that it has been or will be funded. The Clinical Sequencing Evidence Generating Research Program, generating evidence of clinical utility of sequencing sequencing is coming to an end, but we'll probably have an extension coming out. The electronic medical records and genomics or eMERGE network. I'm so sorry, this is a mistake. This is, it's looking at polygenic risk assessment and management. And the IGNITE network is conducting pragmatic clinical trials of genomic interventions. Clinical Genome Resource develops and disseminates consensus information on genes and variants. We also have a growing investigator-initiated portfolio in clinical sequencing research, in pharmacogenetics, and the RFAs that you've recently heard about in genomic medicine and genetic counseling methods, and then a small but growing training portfolio as well. Fiscal 20 is the last year for which we have final data. The total genomic medicine funding was $72 million, and about 15% of that was investigator initiated. This is of a total extramural budget in fiscal 20. I have a figure of $427 million, or about 18% of that went to genomic medicine efforts. And then just to look at how funding for investigator-initiated genomic medicine research has grown over the past 6 years. You can see here, we started off very, very low. It was challenging and remains challenging to get this kind of research funded, recognizing that NHGRI research needs to be, and as part of our mission, non-disease specific, so really generalizable beyond a single disease. And a lot of what was initially being done in genomic medicine was specific diseases, et cetera. This has changed over time as people are looking more broadly across different ways to use similar tools in different diseases. And you can see that there's been really a significant growth in the dollars in millions spent here. This is a provisional amount. It may go up a teeny bit, but this is what we're expecting for fiscal 21. Sort of superimposed on that is the total NHGRI funding for all genomic medicine research here in purple. You can see that the investigator-initiated portfolio has grown more rapidly, and this is obviously on a different scale, up to that 72. We expect it to be, maybe up to 73, 74 million in fiscal 21. And then also superimposed is the percentage of genomic medicine research that is investigator initiated. And again, quite small in 2015, but a growing percentage up to, we anticipate about 22, 23% or so in fiscal 21. So very much looking forward to that, significant jump. And another, and I should mention that our genomic medicine working group has been really very helpful. I'll go back to this one in helping us identify strategies for increasing the investigator-initiated portfolio by identifying various barriers and various aspects of our programs that we could use to stimulate that area of research. The group also looks over our major programs, sort of the timing of them, and when they might be coming up for renewal or discontinuation. Shown here is the timeline at the top for the eMERGE network. It actually began in fiscal 27, so it kind of trails off there, but it is currently funded through fiscal 2024. Our CSER program is currently funded through fiscal 20, but we anticipate extending it for a year due to COVID delays and other reasons for closeout, and then we don't anticipate that will continue. The IGNITE program will likely need an extension as well, again, due to COVID delays and total inability really to start up recruitment for the clinical trials that are the key part of that program. ClinGen is awaiting a decision on its next renewal, and so that would happen in this time period if approved. The UDN will be coming to a close in fiscal 22, and there are many discussions about how to perhaps continue or sustain that effort into the future. The new programs that you've heard about, the PRS Diversity and the Advancing Genomic Medicine RFA, are currently funded through fiscal 25, and we have a new one coming to council, the Genetic Counseling Methods RFA, which is focused really on streamlining and modifying approaches to genetic counseling to make it more accessible to everyone, as well as potentially less time intensive and more cost effective. And just remind you that this is where we are, May 2021. And then as our sort of moving forward, we see as a major effort within the Genomic Medicine Working Group, as well as the division as a whole, really trying to implement this idea of the genomic learning healthcare system. You may recall that was a figure from the strategic vision, where new genomic knowledge is used to generate quality improvement strategies, which then are implemented in practice. Data are collected and analyzed and generate new genomic knowledge, which can then produce potentially new quality improvement strategies, et cetera. They can also sort of spin off to the left here to identify important basic science questions and hypotheses, which may stimulate innovations in technology, again, data collection and analysis, and again, these interlocking virtuous circles. And so we are looking at ways, that we can move this effort forward by mainly at present sort of exploring what kind of efforts are ongoing in sort of learning healthcare systems in general, and then seeing how genomics can be worked into those. And with that, I will stop and be happy to answer any questions. Steve, I see you have one.
Yeah, thanks, Terry. That was very clear and helpful. I guess one just clarification bit. It sounded like there's going to be less. I mean, you've partnered in the past with NICHD and NCI, maybe more disease-specific things. Are you saying there's going to be less of that, or that you're going to be, trying to? I'm sort of suggesting we actually try to spread the net a little bit broader and go after some additional partnerships with, NHLBI, NIAID, NIA, where they all have lots of money. And then also with the new directors that are coming on board, like in NIAMS, who, she's really positive about genomics. And I could see that as a useful thing where, NHGRI can provide insights and expertise that could really help them move things forward. So just wanted a clarification.
Yeah, no, excellent point, Steve. If I implied that we wouldn't be working with our institute partners, that was a misstatement. What I was trying to explain was that when investigator-initiated applications come in, if they are disease-specific, they really belong in the domain of the disease-specific institutes. And this has been a challenge in early genomic medicine implementation efforts, because either they were so disease specific that they really didn't fit in our mission, even though we did work with those other institutes at times to supplement an effort or co-fund it. More often, if an investigator tried to be broader than that, their efforts were viewed in review and in other ways as being too broad, too vague, too general, and not worthy of funding. And that has changed over time, and partly, we hope, because some of the announcements that we've put out saying this is specifically the kind of research that we recognize we need, but it needs to be generalizable. In terms of some of the partnerships that are ending, the Insight program is one that we did with NICHD, the Child Health Institute. That one came to an end because the science was completed, and we are constantly working with NICHD leadership to identify other programs in which we can collaborate. And in fact, the DGTEX developmental GTEX program is a partnership with them that grew out of those discussions. The other institutes that you mentioned were excited and eager to work with them. In fact, we have George Mensa, who's a senior leader at NHLBI, as one of our Genomic Medicine Working Group members, and we've identified some things to work with them on. So great to hear this about the NIAMS leader, and perhaps we can get her to come and tell us about what she's interested in, and we can tell her the kinds of things that we do and see if we can make some partnerships.
Great, thank you.
Other questions for Teri? Al, go ahead.
Teri, I'm wondering, to what extent have efforts focused on or gone out of their way to accommodate end users who are not genetics insiders, primary care physicians, for example.
Mhm.
Are those stakeholders actively being engaged, or is that something anticipated for a later date, once efforts are more mature?
We're doing that in probably at an early phase, but it's been going on now for close to 6 or 7 years, primarily in our Ignite program, implementing genomics in practice, which was designed as kind of a hub and spoke model where there would be sort of specialized centers, if you will, that were more used to doing this kind of thing in clinical care. And then they were, the design was, and they were funded to reach out to centers surrounding them, including primary care practices, community health centers, other such groups. So the Mount Sinai site involved their family health centers in and around the Bronx, in some even fairly distressed neighborhoods, but got a large number of family practitioners and in general internists, primary care folks, really engaged and excited about genomic medicine, focusing on initially the APOL1 variant and its use in managing hypertension in African Americans. And the Duke group has a number of primary care clinics. The Indiana group also reaching out very actively and involving their federally qualified health centers as well as other community health centers. So that's probably the main place where we've been able to do this. I think in a lot of other settings, it has been, there's been less of that, and probably something we need to pay more attention to.
Thank you.
Okay, Teri, thank you very much for the report. We're a little bit ahead of schedule, but because it's an open meeting and we published our start times, we have to stick to the resuming of the meeting at 2 p.m. So you've gotten yourself a little bit longer lunch break here. Please do not disconnect from the meeting. Just shut off your microphones and turn off your cameras, but don't disconnect. And we will resume at 2 p.m. With the current meeting to go through the 4 concepts. So see you in about 40 minutes. Thanks, everyone.